Welcome to AETCM, the emergency medicine channel.
Yes.
A 43-year-old male came to the ER with complaints of fever and acute onset breathing difficulty since one day with vomiting. On our initial 10-second assessment, airway was patent. Breathing-wise, a patient was tachypneic with a respiratory rate of 42 per minute with a saturation of 95% on room air. Circulation-wise, BP was 210/110 with a pulse rate of 160 per minute and a capillary refill time less than 2 seconds. Disability-wise, GCS of E4V5M6, pupils bilaterally equally reactive. Exposure-wise, temperature of 99 degree Fahrenheit with a GRBS of 678 milligram per deciliter. On adjuncts to primary survey, we took an
What
ABG.
is the difference between GRBS and venous blood sample?
GRBS, we'll be looking at the capillary glucose.
That's correct. What is the difference?
20%.
So there will be, definitely there is a difference between venous and arterial. Okay. But when you are using glucometer, there is a 15% error, chance of error is there. So that you have to keep in mind whenever you are taking. That's why it is only used for emergencies. It is not a good investigation for diagnosing the sugar or diagnosing the prognosis in the sugar management.
So on adjuncts to primary survey, we took an ABG, which was showing a pH of 7.11 with a PCO2 of 17, PO2 of 98, with the potassium of 5.5, sodium of 129, lactate of 4.6, creat of 1.7, and a bicarb of 5.3. It was showing a high with an anion gap of 30. It was showing a high anion gap metabolic acidosis with hyperkalemia.
Hyperkalemia. What are the causes for anion gap metabolic acidosis?
So high anion gap could be due to methanol toxicity.
Okay.
Could be due to uremia.
Okay.
Could be due to diabetic ketoacidosis. Could be due to paracetamol toxicity. No, phenol. Lactic acidosis could be there. Then salicylate acid, ethanol salicylate.
What are the acid-base disorders used in salicylate? That is aspirin toxicity. Common metabolic problems. Is it only acidosis?
Hyperkalemia.
Acid-base disorder. This is the one condition you experience all type of alkalosis and acidosis. You can see during the time from the first, after the onset onwards, the acid-base balance will be changing from metabolic alkalosis, respiratory acidosis, like that it will be changing. Okay.
So then we took a CBC-CRP point of care, total counts of 8.9 with a hemoglobin of 18, my hematocrit was 54. With the platelet of 151.
What does it indicate?
Patient is dehydrated.
Severe dehydration produces hemoconcentration.
So with the CRP of 167.
Okay.
Then at this time, sir, we connected two large
albumin?
Sir, initially we...
It is not. No.
So at this point, we connected two large bore IV cannulas and started the patient on hydration.
Okay. What is the basic difference between central line and peripheral line? Which is better for fluid resuscitation?
Peripheral line is better, sir.
Why? Diameter is small, length is small, so the flow is more. Okay, comparing with a central line. Central line is convenient for us. We can give lot of drugs. Different types of drugs can be given through same line. More fluid can be given, but faster rate is not achieved by central line. That is more it is better in a peripheral line. Okay.
So then coming to sample history, patient came with complaints of fever since 3 days, associated with chills, rigor, generalized body pain, headache. He is a known case of type 2 DM on insulin, hypertension, CVA, right lateral medullary infarct. The patient had skipped his insulin doses.
Lateral medullary syndrome is now or previous?
No, known case of right medullary infarct.
Okay. What are the clinical findings of lateral medullary syndrome? If you know, you tell, otherwise You'll just leave it. Huh? So you have to read about that because lateral medullary syndrome is one of the common presentation of stroke. Okay.
So patient had actually skipped his insulin dose and BP medications for last 2 days. Then one day back, he started having acute shortness of breath associated with multiple episodes of vomiting. That's when he came to the hospital. He's not allergic to any known medications, and his regular medications, like his current medications, were he was taking clopidogrel and aspirin, atorvastatin, human actrapid. He was taking 6 units, 664.
Okay.
Then he was on Silacar.
Can a diabetic patient present with stroke where he is not having vascular problem, like there is no vascular injury or vascular thrombosis, can he present with stroke?
Yes, sir. Hypoglycemia.
Hyperglycemia definitely can have all stroke mimicking features, but hyperglycemia itself is a condition that can trigger or precipitate or present as stroke. Okay, so some patients during the DKA they can present with stroke or myocardial infarction, but that doesn't mean that he's got a arterial problem. It is only because of the viscosity of the blood.
Then he was on telmisartan, metoprolol, and metformin.
Okay. What is the action of telmisartan in a diabetic patient? Why we are giving this? Why should we give telmisartan in this patient? He's a hypertensive. Okay. What is the advantage of telmisartan in this patient? It prevents diabetic nephropathy. It prevents proteinuria and it prevents diabetic nephropathy. Metoprolol, is there an advantage or disadvantage?
A disadvantage.
So, as an antihypertensive, it's a good drug. But in a diabetic patient, it has got a disadvantage. That is, it can mask the signs of hypoglycemia. Okay. What is the third drug? Metformin. What is the action of metformin?
So it is an insulin sensitizer.
Insulin sensitizer. Okay. Yes, so this fellow is a very thin individual. You have seen that. Yes, will metformin will be a good drug or bad drug? It's a bad drug. Okay, metformin. So anyway, fat is not there, so it cannot act. It cannot act like a obese individual. Second thing is, it can produce severe anorexia, weight loss. Already he is lost weight. He is not taking food, so metformin can further complicate the condition. Okay, so that's not a good choice here. Beta blocker is not a good choice here. Only your telmisartan is a choice of drug in this condition.
Okay, sir. On the basis of the adjuncts to the primary survey, we are having a provisional diagnosis of maybe patient has gone into DKA due to infection and as well as missed antibiotics. But his
lactate levels are high. How do you diagnose ketoacidosis?
No, sir. We have to send for serum ketones. At the same time, we are hydrating the patient. We will repeat EBG after 2 to 4 hours.
Ketone bodies has to be positive to make a diagnosis of ketoacidosis. Okay.
So we started him with IV fluid hydration. We started with we looked for the IVC. It was collapsing.
Okay.
So we started out 2 liters initially bolused. We bolused the fluid. Then started in 200.
What will be the requirement of this patient? Fluid requirement?
It will be around 5 to 6 liters.
5 to 6 liters. Okay.
And then we started on 200 ml per hour. At the same time, we started with insulin infusion, sir.
What will happen to what you told is correct. What will happen to the blood sugar values when you are starting fluid?
It will start reducing.
It will start reducing. Why it is reducing?
Osmolality will come down.
When you dilute a sugar solution, the sugars will come down. What is the expected range of drop in blood sugar or target drop in blood sugar in these patients? You don't need to start insulin as an urgent treatment. You can wait still you can wait. Even if the potassium is high also you can wait. What is the target blood drop in sugar? Target drop in sugar in your patient?
40%. 10 to 15%. 10 to 15% in the first 3 hours.
What is the drop? Expected drop after starting fluid. It is 75 to 100 mg per hour. Okay, so that is the target. Okay, that is also the target. And when you are giving adequate fluid, that can drop that much. Okay, if it is not dropping like that, then only you need to start insulin. Because if you start fluid and if you start insulin, if there is a sudden drop in blood sugar, what will happen to the patient? Hyperglycemia will not occur when the sugars are 600, 700, even if it drops.
Because osmolality will suddenly
Brain,
drop.
what will happen?
That will cause swelling of the brain and
so you have to
rupture
be
of
very
cells.
careful, especially in children, young adult. The rapid drop of sugar is not at all recommended. So you give fluid, you wait after 1 hour. If the sugar is dropping, normally dropping, no need to give a higher amount of insulin. It will drop. It may drop to 500, 600. Okay. So you have to wait some time. There is no urgency in starting insulin at all in this patient. Fluid is the first choice. Second thing is potassium. Potassium is good here. Okay.
So we cefterized the patient. Also, we started on antibiotics.
Okay.
We started with ceftriaxone in the ER.
What you did for the potassium? Potassium is high.
5.5. So we started
So
insulin.
what you did?
Infusion already.
Huh?
Calcium.
What is the creatinine level in this patient?
Creatinine was 1.7.
1.7.
On arrival.
So in a patient who is having hyperkalemia, this is 5, potassium is 5. What all things you look for?
ECG changes.
So first of all, you have to confirm it whether this potassium is normal or it's a lab error. What are the lab possibilities of lab error in this patient? Hyperkalemia. No, if you put a tourniquet, tight tourniquet, if you remove and keep for some time, all potassium will be high. So you have to, whenever there is a hyperkalemia in a normal kidney function, you have to confirm that that potassium is really high or not. Okay. Then only you should treat. Okay. Anyway, you are starting insulin. What will happen to the potassium?
It will shift inside.
It can normally it can come down. So no need to worry. It can come down. Okay.
So ECG we had taken. It was
What insulin? What is the insulin protocol you used?
So 0.6
Delta protocol. What is that?
Sir,
Delta protocol is introduced by which university? Delta protocol is Yale University's protocol. Okay. So that can be followed in ICU. So apps are available. You can use it. Okay.
So, sir, we then started on infusion, and we 1 hourly we started checking the sugars.
Okay. What happened after 1 hour?
Sir, sugars were coming down.
How much? These things are very important because sugars are anyway it will come down. You start fluid, you start insulin, it has to come down. But your duty is to see whether it is going beyond the limit. Okay. So how much dropped after 1 hour?
400.
Huh?
400.
So it's a rapid drop. That is not advisable in this type of patients. You have to drop that sugar very like in a graded manner. In a hour, in a first hour, it has to drop by only 75 milligram per deciliter. Next hour, 75 to 100. Like that only it should drop. Okay, there is no recommendation for rapid reduction in the blood sugar at all. Okay, so you have to be very careful.
Sir, then because of the patient being very tachypnic, we had started the patient on NIV.
Okay.
And also,
What may be the reason for tachypnea?
so we took a chest X-ray. The chest X-ray showing the patient was having right-sided pleural effusion.
Okay.
So we did also an ultrasound of the chest. It was showing bilateral consolidatory changes with the right pleural effusion of around 400 to 500 ml.
Okay.
So that was the reason because the patient was severely tachypnic.
So what are the causes for pneumonia in this type of patients? What are the causes?
Uncontrolled blood sugar patients.
No. I am asking about the bacteria or virus. What is a common organism which can produce pneumonia in a diabetic patient?
Gram negative.
Which?
Klebsiella.
Klebsiella. Klebsiella is the most common bacteria, gram-negative bacteria, which is seen in diabetic patients. Okay, so that we have to cover, and it can be viral, it can be some other organism, but Klebsiella is one of the important cause. Okay, so you have to cover it. What antibiotic you have started?
Sir, initially it was ceftriaxone,
Okay.
but then we hiked it up to piperacillin and clindamycin.
On what basis you hiked it up?
Sir, patient's procal came out to be 75.
Okay.
So we hiked the antibiotics.
To?
Piperacillin, tazobactam.
What is the difference between ceftriaxone and piperacillin tazobactam?
Broad spectrum.
Both are broad spectrum.
Yes,
So that is the main thing. The answer has to be very clear. Pipta's additional major coverage is Pseudomonas that may not be covered by the ceftriaxone. and ESBL also will be covered by piperacillin tazobactam. That has to be the answer. Okay, if you are hiking up without any reason, we cannot hike. We should know how to hike. We should know what are the drugs we should select. Okay. So it's a bilateral pneumonia. What else is a possibility? What are the other possibilities? Viral. Commonest is viral. Okay, H1N1, COVID, all these things. Then, but that doesn't correlate with your procalcitonin level. Okay, procalcitonin is very high. So viral is only second possibility. What is the other possibility in a patient who is having bilateral pneumonia in a diabetic patient? Pneumocystis carinii is possible. That is also can present like this. It is a common organism which present with bilateral chest infiltrates, cavitatory lesions. Staphylococcus. Okay, so you have to think about staphylococcal pneumonia, this type of patients. So what is the difference between staphylococcal pneumonia and other types of pneumonia? They have more cavitatory lesions than consolidation. Okay.
Sir, so we started serum ketone initially was 3 plus. So like after insulin and hydration, the serum ketones came out to be trace over a period of 24 hours.
Okay.
Then insulin infusion and
Can
potassium.
you check the urine ketones in this condition? Which is more reliable?
Serum.
Serum ketones are more reliable. Okay.
So potassium correction also was started because potassium from 5.8 it went down to around 3.6.
Okay.
Then we also started on potassium 40 milliequivalents correction for the patient.
What do you think the reason for 5.8 to 3.2? It is only shift. Okay, even if you don't treat, it can come back to normal within 1 or 2 days. Okay. What is the urine potassium in this patient?
Urine potassium.
Is it important? What is the magnesium level in this patient?
Magnesium level is
Normal.
1.8.
Urine potassium?
Urine potassium.
Magnesium is only 1.8. Our lab value is minimum is 1.8. Okay. What is the percentage of magnesium present in your blood? Total magnesium, how much is present in your blood? These things are very important. That's why I'm asking. So only 1% of your total magnesium is present in your serum. Okay. So if it is low, means we don't know how much low it is. It can be huge loss from the body will be reflected as only 1.8 or 1.7. So if it is low, means it can be a slightly low or really a huge loss can be there in the body. So we have to be very careful. Okay, especially in diabetic patients. What is the action of magnesium in diabetes? Why magnesium is important in diabetes? Huh? What is the action of magnesium in insulin? Insulin transportation to the cell, magnesium is a very vital element. Okay, so if magnesium levels are very low, insulin will not act like metformin we are discussing. Something like that, it has got a very good action in the insulin transportation into the cell. So we have to be very, very careful. If the magnesium levels are low, we have to correct it. Otherwise, your insulin will not act. Okay.
So currently, sir, patient is getting insulin on insulin infusion on like basal 1 to 2 units per hour. His tachypnea is also subsiding.
So total in 24 hours, how many units he used?
It was around 43
units. So 43 units infusion you are giving for this patient. So when you are switching to a subcutaneous insulin, you have to give something like that only. Okay, 40 units you can give.
Okay, sir.
Okay. Regular insulin. Okay.
And then now his tachypnea is also subsiding. We have removed from BiPAP to now nasal prongs. He is tolerating.
Okay.
Serum ketones are also negative.
Negative. Okay. What is rebound ketoacidosis?
So whenever
this patient you had seen
yes,
that.
Sir, yeah. So whenever we try to stop the insulin, the serum ketones would turn again positive.
Okay.
So we are not being able to stop the insulin.
Okay. Which all drugs are known to produce this type of problem? Newer drugs like dapagliflozin and all can produce this type of problem. Okay. How is this patient now?
So he is improving, but still on insulin infusion and,
Okay.
and potassium correction, hydration is going on. Urine output is good, around 150 to 200 ml per hour.
Okay.
CRP initially was again increasing on piptasclinda also increasing, so we had hiked it up to meropenem.
Okay.
Now CRP is also downtrending.
Is there any fundus changes?
Bilateral NPDR.
Okay. So for that we are giving any treatment? What is the creatinine after that? After
Now
correcting?
creatinine normal 0.6.
Ultrasound kidneys?
Uh,
Corticomedullary differentiation preserved? ECG is normal?
ECG is normal, sir.
Okay. Only thing is when there is a fundal change, you have to continue the AC inhibitor or ARB. That has to be continued to prevent the nephropathy. Okay, it can prevent the prognosis from the progress from proteinuria to chronic kidney disease. So that has to be continued. Okay, what insulin he is getting now? Actrapid. That is short-acting insulin. Okay. If suppose the patient is on analog insulin, so many patients are on short-acting analog insulin, can we continue that drug during DKA? Analog insulin can be continued or not? Many patients you are seeing here, we have a lot of patients are on analog insulins. Can we continue analog insulin in DKA?
Sudden correction of insulin.
Can we continue or not? Yes or no? So we can continue. Even analog insulins can be given as an infusion during acute phase. Only it has to be a short-acting analog, not long-acting insulin. Okay. Suppose you are working in a peripheral center where nothing is possible. Insulin infusion is not possible. Can you give subcutaneous insulin in DKA?
But action.
Action will be less. Only thing you have to give fluids, IV fluids, and even subcutaneous is also possible. Only problem in DKA of subcutaneous is if there is no water in your body, it will not be transported. So if you can give a lot of fluids and if you give subcutaneous, it will have a similar effect of infusion protocol, but it may not be as good as your ICU infusion, but it can give some effect. Okay. Okay, anything else you want to add? Nothing. Okay, thank you.